Today on Inside the Issues, I speak with Jeff Sturchio on the subject of global health governance. Hello and welcome to this week's edition of Inside the Issues, a CIGI online podcast. My name is Dr. Andrew Thompson. I'm an adjunct assistant professor of political science at the University of Waterloo and senior fellow here at the Center for International Governance Innovation. Every week on the show, we're joined by an expert in global governance, international public policy, or some other aspect of international affairs here to the studio in Waterloo. Today, my guest is Jeff Sturchio. He is the president and CEO of Rabin Martin, a health consultancy firm based in New York. He's also the former president and CEO of the Global Health Council based in Washington. Welcome to the show.
Oh, my pleasure.
Jeff, I wonder if we could start. Could you just say a little bit about Rabin Martin?
Sure.
What is its mandate? Who are your clients, etc.?
Yeah, we're a global health consulting firm focusing on strategy, and we look at a range of issues from everything from specific issues like maternal mortality and HIV/AIDS to how companies and foundations can do a better job of using the resources they have to improve health outcomes, particularly for underserved populations.
And how long has Rabin Martin been around?
About 12 years.
Okay. And what are some of the burning issues in the U.S. that you're consulting on right now?
Mm-hmm. Well, I think our practice is really more focused on work outside the U.S., but
right.
we do some work in the U.S. And I think that certainly our focus has been on the great disparities in care among different populations,
right.
Which is something that most people who follow what happens in the U.S. healthcare system would agree is a major issue.
Right. Now, the New York Times has reported on several occasions that despite a fairly rocky start, Obamacare has actually performed quite well, and perhaps even better than most people expected. Is that a fair assessment?
Well, I'm no expert, but I certainly have an opinion on that, as most people do. I think it's clear. Actually, just recently, the Congressional Budget Office had some new figures on the estimate of how much the Affordable Care Act is going to cost over the next 5 years, and so one indicator of how well it's working is that estimate is now about 1/3 less than it was when the Affordable Care Act was passed in March of 2010. So the estimate now is that it will cost about $506 billion over the next 5 years. Another important indicator of how well it's working is that nearly 12 million people have signed up for health insurance,
right.
And that's made a big dent in the uncovered population in the U.S., which has been a major challenge for the U.S. healthcare system for years. So those show that as was originally predicted that the Affordable Care Act would bend the cost curve over
right.
the coming years, and so that seems to be happening from the indicators that we have.
And yet, from day one, it has been under attack. Where is all of this opposition coming from? What is it rooted in?
Well, there are a number of ways that you can look at this. One is some of it is simply it's hard to understand. Let's put it that way. One often hears the criticism that people want, particularly elderly people who are happy with Medicare,
right.
Want the Obama administration to keep their hands off my Medicare. But that doesn't make a lot of sense because Medicare is a government program, and
right.
And by all accounts, most people are happy with the way it's working. I think partly the opposition, aside from the political issues, and I'm really, as I said, I'm no expert in all of that, but it seems that some of the opposition is simply political. It came from a Democratic administration. The Republicans would like to have a different approach. But part of it is just because the U.S. healthcare system is so enormous and so intertwined with all parts of the economy, and because the U.S. population is generally conservative with a small c, that is, change
right.
is difficult to accept,
sure.
just the notion of completely re-engineering the healthcare system that affects just about everyone is something that people are understandably nervous about. But as I said, the evidence so far seems to be that it's working well. And there are a lot of things that people actually like about Obamacare. If you look at the surveys that have been done of the general population, if you ask questions about things that if you ask people in your healthcare insurance, would you like to have your children on the plan until they're the age 26?
Right.
People overwhelmingly say yes. If you ask them, would you like to have insurance in which there's no lifetime cap on your benefits, they overwhelmingly say yes. If you ask them, would you like to have insurance in which there's in which there's a prohibition against exclusion for pre-existing conditions, they overwhelmingly say yes.
Right.
If you ask them, are you in favor of Obamacare, the opinion is mixed. But all of those examples I've given are
Right.
elements of Obamacare. So
Right.
it's just, in part, it's I think that people just lack information, and as I said, they're anxious about something that's so important for their families.
Right.
But I think what's happening, and other observers have made this point as well, is that as people see that millions of people are getting insurance who didn't have insurance before, they see that the subsidies are working to make it more affordable. They see that they are getting coverage for pre-existing conditions, and their kids can stay on their plan for longer. That the dire predictions about how insurance premiums were going to explode, none of that's come true, but they are getting better access to health care
Right.
coverage. I think over time the opposition will decline, and people who are happy with the results will increase.
Right. Moving beyond the North American context, globally, what are the big health issues that we as a global community are facing right now?
Well, it's interesting to pose the question in that way, because the challenges we face in global health are so varied and so daunting in some ways.
Right.
That often people will just focus on one or other particular topic of interest to them, or that they're most concerned about. I think overall the big challenge is that if you look at a planet that has 7 billion people and still a couple of billion people living in extreme poverty,
Right.
the biggest challenge is what are we going to do to ensure that all 7 billion people have access to a basic package of care.
Right.
And that's really the impetus behind, or the issue behind the move to universal health coverage, which the UN adopted as an aspiration a couple of years ago, and which countries are now in the process of working toward. In Canada, of course, you've had universal health coverage with a single-payer system for some time.
That's right.
So this is Canada, the National Health Service in the UK. These are some of the models that that policymakers have been looking at. Now, of course, the challenge, and this gets back to the big issue, is that most countries where the 7 billion people live don't have the level of resources
Right.
that Canada or the UK have. And also, let's face it, we were just talking about Obamacare in the U.S., so one of the wealthiest countries in the world hasn't been able to achieve universal health coverage. So you have to ask yourself, well, how will other countries do it? Right. And I think that partly it will be through defining a package of care. That is, what kinds of conditions will be covered, how much will they be covered, will there be access to different kinds of surgery as well as treatment for chronic disease, and there are a whole range of conditions. But it really requires a complete sea change in the way in which politicians and policymakers think about the obligations and responsibilities they have to the populations who put them in office,
Right.
and how they're going to do the best job they can with the resources available of getting maximum health for the money that they can invest.
And to what extent are the current global institutions that deal with health, and I would include foundations in that category as well, to what extent are they able to help state governments provide or deliver this basic level of care?
Yeah. Well, it's this is a really complex and sort of messy problem. It really is, because we're just think of the challenge. You've got billions of people around the world, most of them, in fact, living in countries with relatively straitened economic resources, and then others in countries like China and India, where 2/7 of the world population live, have extreme disparities in what the wealthy versus the poor are able to do.
Right.
And as it's often been observed, there are more poor people in emerging markets and wealthy countries now than there are in poor countries or developing countries.
Right.
So that remains a challenge for the global system. And so what's happening now is that people are trying to get a handle on what do the challenges look like in individual countries? What resources do they have available? And where can they get help, both in terms of technical assistance and foreign assistance to help meet the gap between what they're able to provide now and what their population actually needs. And at the same time, there's been a change, a concomitant change in the way in which global institutions look at governing the system of provision of healthcare. So, let's just go back to when the World Health Organization was instituted in the late 1940s.
Right.
That was a world in which you had the World Health Organization as the central institution for providing, both normative standards and technical assistance in global health, and its budget was commensurate with the challenges it faced. And they tended to deal with governments. It was largely an intergovernmental organization. And that's the sort of world we had back in the late 1940s. If you fast forward to now, the World Health Organization is undergoing its own reform process. But what's become clear is, and we saw this in the Ebola outbreak in West Africa recently, what's become clear is that the World Health Organization has expanded its mandate, or I should say the member states have expanded its mandate so much over the last few decades that they don't have anywhere near the resources they need to achieve all the things they've been asked to do. And at the same time, the landscape has changed dramatically because if you look at the resources available, the money available for global health, countries themselves don't, or in the developing world and emerging markets, don't actually provide all of the money that they need themselves from domestic resources. So you have tremendous flows of billions of dollars every year from donor countries. But now what's interesting is that the financial flows are not just from donor countries. So this, the notion that had a world in which you had donor countries and recipient countries, and that together with the domestic resources of recipient countries, you could cover all the issues that you needed to. Now you've got, for instance, a world in which remittances from populations who have left developing countries to go live in the north are greater than the flow of official development assistance, and in which, for instance, you now have an institution like the Gates Foundation, which has a budget for its grants every year, which is greater than the assessed contributions of the World Health Organization. And at the same time, you've also got a proliferation of other institutions that are doing parts of the work that were left decades ago to the World Health Organization and governments. Right. So you have public-private partnerships. You have, like the Global Alliance for Vaccines and Immunization, the Global Fund Against AIDS, TB, and Malaria, the Stop TB Partnership, the Rollback Malaria Partnership. There are just literally dozens of these organizations that are taking over aspects of the work that used to be done just by governments and the World Health Organization. And I'm just speaking about global health right now. So what hasn't happened, at the same time that we have this gap between the aspiration that governments have to provide universal health coverage for the 7 billion people on the planet, and the available resources, you also have a challenge in that we haven't figured out how this new complex network of public-private organizations, non-governmental organizations, foundations, and public-private partnerships is actually going to coordinate its efforts to actually achieve the results we'd like to see, which is to let me just stop there for a minute because I lost a word.
Sure.
What we have is we haven't figured out how those complex new organizations are going to coordinate their work to erase the gap between what those who need healthcare coverage actually have and what they need. Right. So it's just, as I said before, it's what some economists and others call a wicked problem, because it's just so complicated. It's hard to see what the solution is.
Well, and perhaps we could focus a little bit on this question of public-private partnerships. Now, you've been involved with at least one very successful one in Botswana, the HAP initiative. Could you say a little bit about this?
Sure. I think that there have been literally hundreds of public-private partnerships in health developed over the last 20 years, and the project in Botswana that you mentioned was one I was involved in when I used to work for Merck Sharp and Dohme, a large pharmaceutical company. It's known as Merck Frost here in Canada. Right. And the idea, this was set up in 2000. The idea was at the time that we looked at setting up this partnership, countries in Africa were really facing an extremely challenging future with respect to the AIDS epidemic, which seemed at the time, frankly, to be out of control.
Right.
There were tens of millions of people infected. The number of infections was increasing every year. Deaths from AIDS were increasing every year. And there were some efforts to deal with it, led by UNAIDS. But it just seemed that African countries weren't getting much traction in actually addressing prevention of new infections as well as treatment of those who are already infected. And by that time, pharmaceutical companies in around 2000 had begun to come up with triple combination therapy that actually provided the prospect of long-term treatment that could turn AIDS into a chronic disease from what was essentially a death sentence. But still, the available resources were out of sync with where the problem was, and there was a lack of coordination of all the different efforts that were being made to address parts of the problem. So I was at MSD at the time, and we thought, what if you went to a country, and Botswana was the country we chose, in part because at the time it had the highest prevalence rate among adults of any country in the world. We said, what if you went to a country like Botswana and said, instead of just dealing with, focusing on prevention, instead of just trying to ensure that more people get antiretroviral treatment, what if you dealt with the entire spectrum of issues in prevention, care, treatment of HIV and AIDS? And that would go from stigma and discrimination at the community level to ensuring that people change their behavior and engaged in less risky sexual practices, that the government actually was testing people to find out who had HIV and then was making the appropriate treatment resources available. And we also thought that it would be useful to work together with the government and also with another partner who could bring other resources and expertise to bear on this. And so we went to the Gates Foundation and asked them if they would be interested in collaborating. And so this program was set up in 2000. The Gates Foundation and Merck & Company each put in $50 million. And the idea was, over the next 10 years, let's try this comprehensive approach to HIV prevention, care, and treatment in Botswana. And the results were, now this idea of taking a comprehensive approach of partnerships in the fight against AIDS is something that's become commonplace.
Right.
PEPFAR, the U.S. President's emergency program for AIDS relief, which has now treated something like 7 million people for HIV and AIDS in the countries that it's focused in, has something like 700 partnerships with private sector entities and others in different aspects of what they've been doing in Africa and elsewhere in the world. So now it's become a common approach, but then this was really the only example you could point to in which a government, a foundation, and a company were collaborating to try to really change the course of the epidemic in Botswana. And the results have been dramatic. Botswana was the first country in Africa to reach universal coverage, which was a major goal of the 3x5 initiative of the World Health Organization. At the time that we started, something like 2 out of 5 babies born to HIV-positive mothers were HIV positive, but now they have almost universal coverage for prevention of maternal fetal transmission, and the percentage of babies born HIV positive has gone from 40% to less than 4%, which is really a dramatic change. And there are a number of other indicators like that, but this approach of bringing together public and private partners, with the government leading the way, it was really the government's strategic plan for how to deal with HIV. The Botswana government has done a good job of coordinating its development partners in this, and PEPFAR was a major focus. I mean, there were plenty of actors who were partners in this, but that partnership really was the catalyst that led to those outcomes. And I think it shows how powerful that kind of partnership can be, because working together, the government of Botswana wasn't able to solve this problem on its own. And working together with the Gates Foundation and Merck and many other partners, they were able to bring together the complementary skills and resources that were needed to really make a difference.
Well, and I wonder if we could maybe talk about indicators for a few moments. And could you say a little bit about the Global Burden of Disease report, the one that came out in 2013, and what it tried to measure and perhaps some of its findings?
Yeah, well, you're referring to the Lancet Commission report called
Right.
Global Health 2035. And that was based on an analysis of a really remarkable database that the Institute for Health Metrics and Evaluation at the University of Washington has constructed over the past few years, in which they look at something close to 200 different conditions and in every country in the world, basically, and are trying to get a sense of what are the trends, what are people dying from, what are the greatest sources of morbidity, and
Right.
really to get a sense of what's the evidence base for what needs to be done to improve global health around the world. And in Global Health 2035, the argument that they made was that with greater concentration on a relatively small number of interventions, we could actually make it possible by 2035 for there to be what they called a grand convergence between the state of health in developed countries and the state of health in developing countries.
Okay.
And one of the reasons for this is that although there's been a lot of attention in the past couple of decades to infectious disease like HIV, AIDS, TB, and malaria, actually the global burden of disease is one in which the majority of the deaths actually come from chronic diseases, or what are known as non-communicable diseases. And the four major non-communicable diseases are diabetes, respiratory disease, cardiovascular disease, and different forms of cancer.
Right.
And so it used to be that people thought that if you lived in a developing country, you died of AIDS, TB, or malaria, or other infectious diseases. And if you lived in a country like Canada or the United States, you might die of a heart attack or of breast cancer or lung cancer or some other chronic condition. But the fact is that what's happened is there's been a demographic transition in the last several decades in which the infectious disease is still a problem, but there's been so much effort to deal with infectious disease that HIV infections are now declining rather than increasing.
Right.
Millions fewer people are dying from malaria than used to die from malaria, and so there's been progress in those areas. But at the same time, the countries that have had a heavy burden of disease, infectious disease, such as countries in sub-Saharan Africa, have an equally heavy burden of chronic disease now. So that and because the resources haven't been put into chronic disease in the way that they have into infectious disease, what you have are increasingly large disparities in outcomes. For instance, if a child in Canada has leukemia, they have something like a 90% chance of living to the age of 5. If a child in most of Africa has leukemia, their chance of is something like 5% of
Right.
living to the, they have a 90% chance of dying before the age of 5. So, and those disparities are just becoming even starker as we understand more about the impact and the burden of these chronic conditions in developing countries and emerging markets. Right now, something like 3/5 of deaths around the world are caused by chronic conditions, and of those 60% of deaths around the world, 4 out of 5 are in developing countries. So it
Right.
just shows how that burden is distributed. And I think the challenge now is to figure out how we can reorient the resources that have been going to other areas. The estimate, there was an estimate a couple of years ago from the Center on Global Development that only about 3% of all of the work, all of the money that goes to health through overseas or official development assistance, only about 3% of that was for chronic disease, and all the rest was for other
Right.
things. All of which are important, but when you look at the burden of disease, there really
Right.
needs to be reorientation. And of course, these chronic diseases also have implications for economic development. It's not
Sure.
just that they cause morbidity and mortality among populations, but David Bloom from Harvard and some colleagues did an estimate a few years ago that suggested that between now and 2030, the global economy would have something like $47 trillion in economic losses if the burden of chronic disease
Wow.
wasn't dealt with more effectively. And a large part of that comes from mental health, which actually wasn't even included in the core chronic diseases when the WHO took a look at this and began to establish programs to really address non-communicable diseases in the aftermath of the 2011 high-level meeting on non-communicable diseases at the UN, when this was taken on as a global priority. So there just is a lot that is still left to be done. The good news, so I don't want this to sound completely bleak.
Right.
The good news is that many of these chronic diseases are preventable.
Right.
And so if we simply do a better job of encouraging people to change behaviors, to exercise more, not to smoke, not to abuse alcohol, and also to eat well, and just not eat junk food all the time, but have more healthy diets, a large part of that burden of disease can be avoided.
Right.
The other part, the reason that that's good news is that it doesn't actually cost as much
Sure.
to persuade people to change their behaviors as it does to treat the outcomes of those behaviors left unchecked. So and of course there's still part of that burden that can't be avoided just because of these behaviors, but a large chunk of it can. And so,
Right.
And in fact, to get back to the question you posed about Global Health 2035, the report in The Lancet, their conclusion is that the single biggest thing that could be done to improve the outcomes and to actually encourage movement toward that grand convergence in which developing countries and developed countries will both have healthier populations is to really press the need to regulate tobacco more
Right.
effectively and to implement the recommendations of the Framework Convention on Tobacco Control. And that alone would have a dramatic impact on health outcomes around the world.
Right. I wonder if we might end off by focusing on the health story that probably got the most attention in 2014 and continues to be an ongoing crisis, and that's the Ebola crisis that hit West Africa.
Mm-hmm.
Is it too soon to draw some lessons from that experience and the global response to that particular
Mm-hmm.
crisis?
Well, I think there are some lessons that can be drawn, and again, I don't want to presume to present myself as an expert on all of this. I haven't
Right.
been in West Africa recently, and I wasn't directly involved in any of the response. But just in following closely what happened and in reflecting on this in the context of these issues that we've been working on over the last couple of decades. I think there are a few key conclusions. One is, and this is actually analogous to the point I was just making about prevention in global
Right.
health. Had the WHO and the rest of the global community mobilized sooner, the human consequences of that outbreak would not have been as great. It was the first cases occurred at the very end of 2013. It wasn't until August of 2014 that the WHO declared it an international health emergency. And then, within a couple of months of that declaration, all of a sudden, you had the U.S. sending 3,000 troops. You had the U.K. and France
Right.
and others.
Security Council.
Yeah, exactly. It was taken. So it really was taken up then as a priority. And I don't want to denigrate the progress that was made because, at that time, in August and September of last year, people were predicting that there might be as many as 1 million people affected, or more than 1 million people
Right.
affected in that region, and that those predictions never came true. That because the number of people affected was in the tens of thousands, and that was as a consequence of actually taking those actions and implementing some of the basic public health precautions that were required for an epidemic outbreak like that. So that's one thing that had action been mobilized sooner, the course of the outbreak might have been handled more efficiently and with fewer people dying in the end. But the second thing is that the experts who have been looking at this, and that involves people like David Nabarro, who led the UN's response, and Tom Frieden, the head of CDC in the U.S., Peter Piot, who was one of the co-discoverers of the Ebola virus and who has been active in thinking about how to improve the response to this
Right.
outbreak, and many others, is that there were certain basic public health precautions that the public health community has known about for years, in which you isolate the people who are infected, you trace their contacts, and then make sure that you monitor those contacts for the 21 days to see
Yep.
if they've actually developed Ebola. And had that been done more systematically, again, it probably would have even moderated the outbreak. But the challenge was that, and this is the third point, that the health infrastructures in the countries that were most directly affected, Guinea, Sierra Leone, and Liberia, were really, there's no easy way to say this, they were very weak because because of conflict situations, and they were still, the economies were recovering, the government was recovering, the society in general was recovering from years of conflict in some cases. And let's face it, these are still relatively poor countries, so they simply didn't have the kind of healthcare infrastructure that would have been required to implement those public health measures. And then also, this legacy of conflict and having weak governments in recent years also led people, the population, to be skeptical and sometimes hostile to government. And so, there's even been analysis of the outbreak being in parts of the country, in these countries where opposition politicians came from, and so the government, some people have argued that the governments may not have moved as quickly as they might have otherwise. I don't know if how much credence to put in those kinds of rumors, but the point is that you had weak healthcare infrastructure, you had governments that were just barely hanging on, because of the impact of the outbreak, and then you have this residual kind of skepticism and even hostility toward government action. So that kind of is just a recipe for disaster. But again, the bright side is that now Liberia appears to be Ebola free. The number of infections has been declining over the past couple of months in Guinea and Sierra Leone, and it looks like the help that the global community has been able to give to those three countries has turned the tide on the epidemic. But and also I should say that there's been a really dramatic effort on the part of a number of pharmaceutical companies, including Merck Sharp and Dohme and GlaxoSmithKline and Janssen, to put new candidate Ebola vaccines into clinical trials much more rapidly than has usually been done. And that's been a result of collaboration with the WHO and with regulatory authorities around the world. I just read that the Merck vaccine candidate is going to go into phase 3 trials in Guinea fairly soon. So that's moving along very quickly, and hopefully that will lead to vaccines that will be helpful for the next outbreak.
Sure.
But I think the other lesson to be learned from this is that there have been Ebola outbreaks regularly in Africa over the last several years, and this one was different in that it was the first time that it actually came into urban populations. But there's probably Strive Masaiwa, who's the head of Econet Wireless and has been he's special envoy for the African Union on the business response to Ebola in Africa. He observed when I had a chance to talk to him recently that there's probably another Ebola outbreak in Africa right now. It just hasn't come to light yet. It probably is in some far some rural area, which is more more a traditional route for the outbreaks to happen. But the lesson that we have to learn is next time we have to be prepared to apply the lessons of this Ebola outbreak.
Right. Jeff, this has been absolutely fascinating. Thank you so much for joining us.
Well, thank you.
And thank you to our audience. You've been watching or listening to Inside the Issues, a CIGI Online podcast. Look for us online at cgonline.org, on Facebook, on YouTube, and on Twitter.